Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Setting the teeth for an immediate denture, setting the anterior teeth, is the responsibility of the dentist and not the laboratory technician. The least that the dentist should do is, if the laboratory technician is going to do the work, is to provide him with some guideline of how much bone to remove, or stone, which represents the hard tissues around the teeth, to remove. So when the denture is placed at delivery, that it fits without having to remove too much bone from the mouth during the surgical procedure, or to have to relieve too much from the cast. So the first thing that we should look at is the relationship of the bone to the teeth. And this cannot be done by looking at a cast itself. And that's why, if the laboratory technician is going to do the work in the preparation of setting these anterior teeth, the dentist should give him some information. Now, as an example, I have a cast here for a candidate for an immediate denture of a woman 80 years old. And from the soft tissues, and this is all that the cast tells us, the gingiva looks in pretty good condition. As a matter of fact, the margin in the gingiva is at the CE junction, or actually the cemental surfaces are not even showing on the root. So for an 80-year-old woman, this is very unusual. But this doesn't tell us very much. In other words, we have to decide how to contour these areas as we set the teeth, so that when we deliver the denture, we don't have to remove any more bone to get the denture in, or that we don't have to relieve too much of the denture itself. So the two things that we must look at is the height of the bone, actual bone, around the tooth. And the way to do this is the periodontal probe. We can actually do a periodontal examination very quickly on these teeth and find out if the patient does have deep pockets and so forth, and indeed maybe the bone level is someplace like this. It's possible. And the second diagnostic information we can gather is the radiograph. So I actually have radiographs here of this patient, and now as we look at those radiographs, we can see that indeed the bone level is 4 millimeters, approximately 3 or 4 millimeters, or even more in some cases, from the CE junction. In other words, the cast that we just saw did not give us the information that we needed to know. So for the delivery of this immediate denture, it would be important that this casts were prepared in such a way as that whoever set the anterior teeth knew the approximate bone level after the surgical procedure was accomplished. So using radiographs and using the periodontal probe, we can determine about how much we want to remove around the teeth. Now, in setting the anterior teeth for the immediate denture, there are several instruments that we need. One, of course, is a rotating handpiece, and in that we have our several instruments that can be used very nicely to both remove the stone teeth and also to remove the or reshape the acrylic resin teeth that we are setting. And here, as an example of some instruments that can be used, we have a regular acrylic burr. This happens to be a carbide-tipped acrylic burr, and this is good for both removing stone on the cast and also for reshaping the acrylic resin tooth. The second thing, probably the second most useful, is a simple cross-cut fissure burr. And this works very well, again, for reshaping the stone, not so well for reshaping the tooth. Or you can go to the gemstone type of rotating burr or stone, which works best for reshaping the tooth itself, either the biscuit type or the large disc type, or a variety of these. There's no set rule on which you should use, but whichever works best in your hands. These are just some suggestions. You will notice that I will use mostly the crosscut fissure when I adjust the stone cast, and I will use the carbide tipped acrylic burr for adjusting the tooth itself. Now, for the immediate denture, we normally use acrylic resin teeth, or we always use acrylic resin teeth. And what I have here is a selection that has been made. We won't talk about the selection of teeth at this time, but I have a selection of anterior teeth which are made of acrylic resin. And these can be shaped very nicely to conform to the character of the tooth that we're working with. And by a little pumice after the grinding, a little flour of pumice, and then following that with some polishing material such as Bendix, the character of the tooth can be brought back to the original polish very nicely. Now, the case that we're working on in this exercise is mounted. At this time, we have determined our condylar determinants and our incisal guidance. And what we want to do now is to begin to replace the stone teeth in the anterior portion of the mouth with the acrylic resin teeth of the denture. See, all the patient has left are the anterior teeth. And to do this, we go through various procedures in determining how the tooth should be taken off, how much of the soft tissue should be removed from the cast, representing the surgical procedure when it's completed, and how to go about that is the purpose of this television demonstration. So in order to make it easier, I think I will remove the maxillary cast and actually set it in by itself, and then we'll put it back on the articulator when it comes to finding out if it articulates correctly. Now, there are several ways to replace the teeth for a maxillary denture. One way simply is to remove all of the teeth at one time and reset the teeth with the acrylic resin denture teeth. But doing this, we really lose the advantage, one of the advantages of the immediate denture. Because if we want to replace these teeth in the same relationship as was normal in the patient's mouth, we need all of the indices that we have. We don't want to lose the relationships between the teeth. So another way to do it would be to remove every other tooth. In other words, we can start out with a central incisor, replace it, leave the lateral in the stone, but go to the cuspid. And then when that's completed, finish the lateral. And doing that, we can set the teeth exactly the way they are here. Another way to do it, works just as well, and this is the way I will demonstrate today, is to go tooth by tooth. In other words, we'll start with the central incisor. And when we have that replaced, we can tell by looking from various angles the relationship of the incisal edges and so forth. When we have that tooth set to our satisfaction, then we will remove and prepare the cast for the lateral incisor, and when that is ready, go on to the cuspid. And that's the method we will use today. Now, the first thing that we do is put some guidelines on the cast by marking in pencil the junction of where the tooth surface meets the soft surface of the gingiva. So I'm simply going around the cast and marking that junction with a pencil. And then there are a couple of other anatomical structures that we don't want to remove in stone because they are not going to be involved in the surgery. And one of those, of course, is the labial frenum. And when we remove stone to set this tooth, there's no need to damage what represents the labial frenulum because this will not be involved in surgery. And the other structure is the incisive papilla. Now, you know from edentulous mouths, this structure remains after the teeth are removed. This will not be removed surgically, so let's not impinge upon it by removing it in the stone at this time. So that remains. That's just a guide to remind us of that. Now, when we remove the teeth, we will not remove any of the soft tissues from the lingual. From experience, we know that when resorption takes place, this is not the area that is grossly involved with resorption. So as a guideline, we will go down no farther than the black line that we have drawn. On the labial, however, it's a different story. And we will not only remove the tooth down to the junction of the gingiva and the black line, but we will contour the ridge even further depending on the depth of the gingival sulcus and the bone level. And to do that, we just mark a guide for ourselves depending on the information we gained from the radiographs and the periodontal examination. And you'll notice that I'm drawing a line in the cuspid area that's a little greater than it was around the other two teeth. And there are reasons for this. I think if I move this in this direction, you can see that there is more of an undercut in the cuspid area than there is around the other teeth. And during the surgical procedure, the way we perform the surgery at this school, it is common procedure to actually remove some of that bone around the neck of the cuspid before the tooth is extracted. And this is actually a preventive measure so that we don't bring a labial plate of alveolar bone with the cuspid as is extracted. And this can happen quite easily. Not only that, we don't want that great an undercut under the denture itself anyway, so contouring the alveolus in this position is to our advantage and to the patient's advantage. Now the first step in the procedure actually is to remove the first tooth, and this will be done. I'm going to use the cross-cut Fisher burr that I mentioned a moment ago. Now in the first step, I'm trying not to remove the stone on the lingual any farther than the level of the line I made with the pencil. And also, as part of the first step, on the labial, I'm only removing the stone to the gingival line also. Now this time I've simply removed the tooth, and I have not made a socket in the stone. As a matter of fact, as you can see, I've actually rounded it, contoured it, such as the ridge is itself. And at this time we can take the blade of a scalpel and actually remove any excess stone we have or any ridges. And this completes the first stage. Now, as a general rule, and this has to be given only as a guideline because, of course, every case is different. That's what makes this procedure so difficult to teach. But as a general guideline, it is wise to deepen the anterior part of what represents the socket. Now, remember, these teeth are not being socketed in this case. We are ridge lapping these teeth. And what we're trying to do is guess, as well as we can, with as much information as we can, what this ridge is going to look like following surgery. That's our goal. And we know that this stone here represents soft tissue, and once the tooth is removed, depending on the height of the bone, it will not have the same configuration. So this will give us room to ridge lap the tooth if we remove some of this. And the second line that I have drawn is only an index, is how far to go when we recontour this ridge. So the second step is I'm drawing a line about the midline of the socketed area. And from that midline forward to the gingival margin that we still have marked here, I'm going to deepen that as we come forward about 1 millimeter or 2. And then the third and last step is to go from there and contour and round up to the second line. And this is just a general rule to follow. And what we will end up with, hopefully, is a ridge that represents the way the ridge will look after the surgical procedure, after the extraction. So as the next step, I am going to deepen the area where the tooth has been removed. And as I said before, depending on the case and what we have found from our diagnostic examination, it depends on how much we do of this. Now you can see from this that we have actually contoured and deepened the sulcus in the anterior part. And the last step for the central incisor is to remove the stone in a contouring manner now, not just deepening the socket, but in a contouring manner up to the second line. So I'm going to do part of that with the crosscut fissure burr, and the last part of it with the blade of a scalpel. And we want this contoured and smooth very nicely. Now, as you can see from this is as far as we are altering the stone. And also that the area that I'm pointing to here with the pencil has not been surgerized. So the flange of the denture should be very thin in this portion, because any thickness of the denture base that we have in this area will simply be supporting the lip more than the lip has been used to. So it will look like it's too bulky. So the area involving the surgical extraction will only go to about this level. At this time, the ridge has been, although I haven't touched it up with the scalpel blade yet, but at this time the ridge is in the approximate position to be readied for the tooth. Now, as I turn it down, you can see the contouring of it. I don't have a socket. I have not dug out a socket in this case. There is a method of making a denture, of course, by making a socket and actually placing the tooth in that socket. And we are not doing that. This will look like a normal denture when it is completed. Now, the next step is to contour the tooth that we have selected, the acrylic resin tooth, so that it fits the cast. And as you can see now, it is too long. And I have to contour that so it fits the ridge that I've just prepared, and that it can be adapted so the incisal edge and the axis of the tooth is in the same relation as it was before we removed it. Now, the important thing here that I'd like to point out is, even though we have to adjust the tooth, it is important to maintain the incisal cervical length of the tooth. If it has to be shortened somewhat, and it does, it has to be ridge-lapped. In other words, we have to adjust this portion of the tooth in order to lap it over the contoured part of the stone. But it is important, if we can possibly do it, to maintain the incisal cervical length of the tooth. The tendency when first starting to set teeth of this kind is to take too much off the cervical portion of the tooth, and that is not necessary. For retention of the denture, we want the acrylic resin to come down over the neck of the tooth to hold the denture. So this is an important point. At this time, I'm going to change burrs in my instrument and actually place the carbide acrylic resin burr that I mentioned before. And by looking at the tooth, I can tell from my view, I can't show this very well on the television, that I'm going to have to remove some of the tooth in order to have it fit on the cast properly. Now, this is very difficult to show because I have to see what I'm doing. And with these sharp burrs, we usually get a few nicks in this procedure. It's very difficult to hold a small tooth without getting very close to that rotating burr. Now, at this point, I've actually reduced quite a bit of that tooth in a ridge-lapping way, but let's see how it fits on the cast again. Now, we are getting closer. But again, I can see from my view that we do have a little more to remove. So just by going back and forth like that a couple of times, we can shape the tooth. I am taking a little of that length down because we don't need all of it. back and forth and once again try it on the cast. And when it looks like we are ready to place it on the cast, and I have a little bit of central incisor left on my lateral, so I'm going to remove that. At this time, let's try to wax the tooth into place and see if we can make it look exactly like the other one. So what we do here is simply use the base plate wax for the material, because actually the denture will be waxed in that. We don't need sticky wax or utility wax or anything like that. We'll simply use the base plate type of wax. And the first step will be to wax the tooth in place and then make further minor adjustments as we deem necessary. Now, if the stone cast is wet, it's very difficult to make this stick, so I would advise keeping the cast dry during this entire procedure, if you can. I've simply put a little orange or pink wax in place. I'm kind of doing this upside down, but I think that's going to fit very nicely. And we make our initial placement of the tooth. Now you notice that the patient had a diastomy in the tooth in the setup before, and I am simply replacing that. As a matter of fact, what we like to do here is make sure that we keep a study model so we can go back and forth and set the teeth exactly the way we want to. We have a guide, even though we've lost a tooth. So we keep referring back to the study model when we set these teeth. Now, we've discussed with the patient beforehand, of course, as to how much of a space should we leave in the denture. Some people are conscious of diastema and want them left in. Others take the opportunity at this time to rearrange their teeth and make a difference in their appearance. So this has to be discussed with the patient. And in the exercise, it doesn't matter which way you want to do it. If you want to try to set them exactly the way they are in the cast, this is perfectly all right. As a matter of fact, it's more of a challenge to do that than to set them up in an ideal denture type of setup. Now, another thing that we look at this time, of course, is looking straight down on the denture, and I'll rotate this around. We have the incisal edges of the central incisor and of the lateral incisor to align our denture tooth. And this is the advantage of the immediate denture. We have all of these indices. And at this time, we can go back to the instrument and place the cast back on it and examine the relations at this time. And what we can see here, of course, is although we have the labial portion aligned correctly, it appears to me, looking at it, that we have closed our horizontal overlap. The space that you saw, or that you can see between the stone teeth, does not exist where we have replaced it with the acrylic resin tooth. But because we want to keep the labial surface where it is, in its normal position, and the incisal edge where it is, the way that we can increase this, of course, is to thin out the lingual portion of the incisal. And this will once again give us our desired overjet, or horizontal overlap. And I will do this. So at this point, I'm going to go off camera for a couple of minutes and make the final adjustment on this tooth, and then start preparing the lateral, which is done exactly the same way. At this time, I have completed setting the lateral incisor using the same criteria and guidelines as we used in setting the central incisor. Now, you'll notice another advantage of setting teeth this way is that we still have the gingival contours next to the teeth that we're setting. So this helps us in setting and adjusting the gingival contours of the teeth that we're replacing. And I have already done this at this time. Now, the last tooth to set here, of course, is the cuspid, and I have left this because I want to demonstrate taking off the undercut area, or the collar of bone around the cuspid, which does form an undercut and should be removed for the denture, and as we mentioned before, is done in the surgery to take the tooth out. Now, in this case, I'll show you the other side too. It is quite a dramatic undercut, and if we don't remove these, the patient has trouble wearing the denture. The denture has to be relieved so much to be put in its proper place that we lose retention and so forth. So the loss of this bone is not a disadvantage to the patient. And I will demonstrate how much we take off. At this time, I have my crosscut fissure burr back in the handpiece, and as we did before, the first step will be simply to remove the tooth portion itself, going no farther in the first step than the line that we've drawn at the margin of the tooth surface and the gingiva. And on the lingual, once again, to repeat, and it's important, don't go any farther than the lingual. We will take no more off this area than we have right now. Now the second step, of course, is to, from about midway across the area toward the labial, deepen that socket a little bit. Actually, this can all be done at one step, but if we do it slower in stages, we don't lose the perspective, because it is very easy to take too much off if we just start removing bone to end up with a good-looking ridge. We have to know how much we are taking off. And at this time, the second stage has been completed, and you can see that we're getting now from this area forward, we are getting some contouring. Now this is about 1.5 millimeters to 2 millimeters deep from approximately midway forward. Now we still have the undercut to be removed, and that is the final step. So once again, either with, at this time, the scalpel or the burr, we will remove stone, which represents bone to be removed in the surgical procedure. And again, we're keeping in mind what we want to end up with as the final contour of the ridge. Actually, the inside of an immediate denture, the configuration of the inside of the immediate denture over the surgical sites has some influence on the eventual shape of the ridge. So if we deliver an immediate denture that has sharp projections into the surgical sites, and we don't do anything with that for a year or two, the bony remodeling will probably be influenced by that, and we'll have a ridge that's very irregular and probably more bone loss and resorption than we desire. So at this time, we have prepared the cuspid area. Now if you look at this direction, as I rotate it around, you'll see that I have contoured. I have not deepened or socketed the cast, but I simply contoured it. And it looks, hopefully, the way it will look after the tooth has been extracted. The next step, then, obviously, is to take the cuspid tooth, which I have here, and placing it on the cast, I can see that it comes out too far. It's difficult to show it here, but it'll be easy to do when you do it with your own case. And obviously it has to be ridge lapped. And once again, maintaining the height of the tooth as much as possible, but ridge lapping the tooth so that it sets on the cast properly. At this time, I will go ahead and ridge lap the tooth off of camera and come back with the cuspid in place. Now the cuspid has been added in the proper relationship to the ridge, and the three teeth wax as to their gingival configuration. Now at this point, it looks from this view like I have a lot of overbite, vertical overlap, but we really don't, because as I tip the articulator up, we can see that the space that we began with, the overjet or horizontal overlap, has been repeated. Now this was done both by the alignment of the teeth and also the thinning of the incisal edges. We do not want contact in the immediate denture any more than the regular denture with the anterior teeth. Now you can see that the gingiva has been contoured, and I have used the gingival contours of the adjacent teeth as a guide for that purpose. Now as I loosen up the condylar mechanism of the articulator, you can see that I have paid some attention to the working as we set the articulator. Now as we move into the working excursion, of course we can't do anything with balancing at this time because we haven't got it set up yet. But as we move into the working excursion, you can see that the teeth will clear without catching anything. And as a matter of fact, later when this denture could be adjusted, minor adjustments could be made. But if we had a 4 or 5 millimeter overbite on the cuspid, for instance, it would be a cuspid guided occlusion, and this we do not want. But as you can see, the lateral and the cuspid come through very nicely, and if the posterior teeth are set using the condylar determinants of the, or end controlling determinants of the articulator, this case can be balanced very nicely. The next step, of course, is simply to set the 3 teeth on the other side of the arch in exactly the same manner as we have used to set these 3 teeth, and this will complete the exercise in setting the anterior teeth for the immediate and maxillary denture. Setting the posterior teeth for this exercise will not be demonstrated because we found from experience before that the students have been able to do it very easily after setting the denture teeth in the other exercise, but I would like to make a few comments about it. As you'll notice, if you look on your lower model, you will see that some of the cusp tips of the natural teeth have been flattened somewhat. And this was done very carefully on purpose so that the eventual occlusion of the denture would be better. Now you notice there's quite a curve of speed, very dramatic one as a matter of fact. And this helps balance the case. And as you set the posterior teeth, attempt to balance the case. We can't observe this or check this after the material is handed in because they will not be articulated. But make an attempt to do it as you set the teeth. Now I have another model here showing an actual case that was done where the same type of thing, this is a natural dentition in the lower, and the first thing we look at is the occlusal scheme. And in this particular case, from this angle, there were cusp tips that were sticking up into the air 2 or 3 millimeters so it would above the plane of occlusion, so that it would be very difficult to articulate a maxillary denture against it without having a very difficult occlusion. The patient would not have much stability with the denture. So the areas marked in the red that you see were areas that were actually flattened off, reduced somewhat in the mouth. We don't like to go down into the dentin. This is all done in enamel, but it does give the patient better occlusion in the denture. So this has been done on the case that we're working on. This was an actual case that was done in the clinic, and we saved the master models, saved the mandibular models. Now the teeth that you have for the exercise are the functional teeth that we talked about before. It is a cusp tooth, an anatomic tooth that has been milled. And if you look at the cusp tips, you will see flat areas on the cusp tips. The angles are the same. The cusp heights have been reduced. This is a fairly common tooth that is used in denture construction. Now we're using a cusp tooth because we have cusp teeth on the lower arch, of course. The important thing is that we end up with good, solid, centric occlusion. That's the first thing. And to do that, the buccal of the lower should be in the middle of the maxillary tooth. And that is, the denture teeth are not really large enough to interdigitate perfectly with the natural teeth. And this is common when setting the immediate denture. It would be rare to get perfect occlusion because we cannot match the individual's natural teeth. What we do aim for is a good, solid. We don't want centric occlusion contacts on a sharp incline. Good solid centric occlusion. And we also want to end up with buccal over jet. Don't have the posterior teeth ending up end to end, but we want buccal over jet. And we talked about this in the lecture. And then, of course, try to balance the case. Now, when the denture is done, when you set against natural lower teeth with artificial teeth, it's not unusual to find spaces because the teeth are, of course, not the same size as the natural teeth. If you do have a space of 1 millimeter or so occasionally, there's no problem with that. As long as the teeth articulate properly, that is the important thing. And also, the case does balance fairly well, so attempt to balance the case as you set the posterior teeth. Now, to complete this exercise, we will wax the immediate denture, but it will not be processed. In fact, this is the end of the exercise itself. The waxing procedure you have done before, you've all gone through it in the complete denture, and we do it exactly the same way for the immediate denture. So use the same guidelines, criterion for waxing up the denture. Now, to hand it in, take the mounting, separate the mounting from the master cast, and also separate the mounting from the lower cast. And to be handed in, put your name on the cast some way, both casts, so they can't be separated, and then we'll just hand articulate the models. And they will be handed in this manner at the end of the course. And you will be directed when and where to hand it in. But it's important to save the lower cast, so when we look at your work at the end of the semester, it can be handed to us in such a manner as this. So this completes the comments on the posterior occlusion for the maxillary immediate denture.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.